Uh, Welcoming you again, and we are talking about the four phakic IOLs. The most popular of these is the ICL, also known as the EVO ICL. It is called first the EVO Vision ICL, but now they have dropped the name Vision, so it is EVO ICL. And we are showing how we do this under hydro insertion. So you see two options, the hydro insertion and the visco insertions. So this is purely under hydro insertion. You make the ports, and when you make this main port, the eye should be firm or tight. If the eye is loose, you may hit the anterior capsule. Load the lens, and now the irrigator is what is maintaining the chamber pressure at an IOP of 40. It's a low IOP, 40 or 50. The lens is injected over the iris. Since it is hydro insertion, there is virtually no visco. Just a few threads which were in the injector cartridge, which just come out in 5 seconds. So it's virtually visco free. And then you tuck in the haptics. The whole surgery takes just about 5 minutes. And the biggest advantage of hydro insertion is that the fear of a raised IOP, first day post-op, is over. We have not seen in the last 3 years any case of a raised IOP post ICL in the first week. Talking to a lot of people who started using ICLs, the raised IOP is a major issue. The IOP goes high, the patient is complaining of pain, the cornea becomes hazy, the vision is not too good. The patient expectations are very high because now they are using a procedure which is almost twice the cost of the laser procedure. And if he does not get immediate good post-op vision, he is demoralized. And the surgeon is even more demoralized because he is marketing a procedure which is so expensive, as if it is a miracle for the patient. So we realized with time that this technique of hydro insertion comes naturally if you do the first 5-6 cases, and then you would not want to revert back to the visco insertion at all. We'll come back to it again later. Now, this is the biotech phakic IOL. We do it under hydro insertion also, but here I would be showing you visco insertion. So we'll show you both the sides of the same coin. So this is visco insertion, the technique which we are most used to doing. The incisions in all my phakic IOLs I've kept at 3.2. So the eye is now firm with viscoelastic. The advantage of visco insertion is there is a little more control in your hands because the chamber is very stable all throughout. So maybe for a beginner, we would recommend a visco insertion because at that time you are still fumbling. Now this is a biotech lens. It looks exactly like a star lens, except that the holes are left leading, right trailing. In star, it is right leading, left trailing. And in star, the axis is on the vertical edge. Here, the axis can be in 5 different meridians. So you just have to move the lens by about 15 degrees either side. So you could have at 45, at 90, at 135, at 0, 180. So here you see, this is the axis mark, which is at 90. Lying in the eye right now, it looks exactly like a star ICL. This is the hole in the left leading. The manipulations for a beginner are smoother, definitely, in a visco insertion. So probably your first cases should be visco insertion with this inherent fear that you may have a rise of early IOP and bringing the lens into position. So actually, inserting an ICL is not a very great surgical technique, but it comes with a great amount of fear in the mind of a surgeon. The fear of cataract, the fear of glaucoma, the fear of the ICL hitting the anterior capsule, the fear of what if this young patient develops a cataract, he'll be after my life. You're dealing with very young eyes and you're promising them a lot. And the parents are very sensitive about their children. Very, very sensitive. They are not that sensitive about an old man who's undergoing cataract, but they are very sensitive about the kids. So that is where the surgeon's fear develop. Then we have this IPCL from CARE. Again, I'm going to show you a visco insertion. Now, IPCL is comparatively when you feel a thinner lens. Star is the middle level lens, which is very comfortable to manipulate. Biotech is a thicker, harder lens. CARE is a thinner, even more flexible and a soft lens. It is almost kind of a little uncomfortable to manipulate around because whenever you press it, it gets pressed the whole way. But other than that, it's a good lens. Now, this is the typical shape of this thing, left leading hole and a mark here in the left leading, mark here in the right trailing. And there are these two holes here because each manufacturer has to have something different. So it's not a copyright infringement. So these two holes come under the upper lid, always. So you have to be careful that you don't put the lens in such a way that the holes are facing down, because then they will come into the visual area. These two holes have to be covered by the lid. So insert and let it open up slowly, again over the iris. Now the lid is here, so these two holes are always placed superiorly. Now these are smart lenses. That means you are always putting it at 180. And they come with the pre-built axis. And there is no way to know that in a lens where the axis is. You are assuming from the box that what you ordered and what you have got is what the axis is. And it's right. But you have to depend on them that they are delivering the right axis. All you have to do here is remember that this is a smart lens. When you say smart, you're always putting the lens at 0, 180. And trusting that the company has put the axis at the right axis. And that the result will tell you on the next post-op day. So you don't have an option that you can turn the lens around to the right axis or whatever. Nothing. Just 0, 180. Since it is a thinner lens, we have a tendency to use it. Since it is a thinner lens, we feel tempted to use it in powers which are beyond 18. So 1 to 18, or you can say 8 to 18, because 1 to 8 is usually LASIK. 8 to 18 is phakic IOLs, which by choice we go for the star ICL because of the brand value. And then when it is beyond 18, we tell them that we don't have a star lens in this range, so we are opting for the other ones. And the patients accept, rather than doing a bioptic. That means you put 18 powered ICL and then you do a LASIK on the top. Why do two procedures when in one lens you can cover the entire number? So biotics have gone out of a curriculum now because we can correct up to 25, 26, 27 with the phakic IOLs itself. And that makes a lot of difference and makes a lot of sense. And when we do these higher powers, we have biotech, which is local, they can customize, and the care group, which is local and they can customize. So if you have very high powers or high cylinders, 5, 6, 7, 8, one has to depend on these lenses and they deliver. All the lenses deliver. That is there. Somewhere there will be minor variations, I would tell you. Now this is a medium phakic lens. Previously it was launched as the PRL, phakic refractive lens. Now it can correct up to minus 28, but it is only a spherical lens. Why spherical? Because it does not go into the sulcus. It is a shorter lens and it is kind of floating in the center. Now, if it is floating in the center and it is a shorter lens, you would wonder, how does it stay in the center? It could just flow to one side. So the technology which they say works is like a parachute. In a parachute, at the top of the parachute is a small hole. And then when the air from below moves up through the small hole, it stabilizes the parachute. So this also, when the fluid is moving from inside upwards, it stabilizes the lens in the center. And that is why the lens does not fall to one side or to the other side. We have used about 20 of these and they worked. We were apprehensive that there's a lot of talk, but does this technology work? The technology worked. So now we are going to inject this lens. This is a silicone lens. Compared to others, which are HEMA lenses. So this is the lens, the central optics and the side flanges, which are not reaching out to the sulcus. Since the haptics are smaller, I could tuck both the haptics or the plate at one time. And then I constrict and the lens stays in the center. Why we have almost stopped using these lenses is because we were using these lenses when the powers were high, 25, 26, 27, 28. And almost 100% these high powers are associated with the cylinder. Almost. Anything more than half is what we correct. But they usually have a cylinder of 1, 2, 3. All these very high powers. And since we have started getting these care lenses and the biotech lenses in the same range with the cylindrical correction, the need for these lenses, we don't find it of any definite use in our clinical practice. So, I would ask Dr. Rahil. Dr. Rahil, are you ready? So before we move on, we'll give you a little idea about a workup, just the salient points in a workup of what is important in your ICL practice, and then we'll take you to the higher levels. The higher level would be cataract and glaucoma fears. That is the main thing that troubles the mind of every ophthalmologist. What if there is a cataract? What if there is a glaucoma? How do you prevent it? The aspect on prevention is more. Can you take the dice? The aspect on prevention is more than an aspect of treatment, because treatment of cataract has to be a cataract surgery. So we will be focusing more on the prevention part. Then I will take you into the details of hydroinsertion and viscoinsertion, merits and demerits of both. And then we will actually compare the 4 phakic IOLs.